Hello and welcome again. By popular demand, we have our good friend Carol Petersen, who, if you've missed our first interview, it's very interesting, and we had a lot of very positive responses because Carol has a bachelor's degree with University of Wisconsin from the School of Pharmacy. For the past 25 years, she has been working with Women's International Pharmacy, compounding bioidentical hormones and working with different bioidentical therapies. Carol writes and edits a newsletter called Connections. And with her work at WIP, she attended, or generally attends, around 20 medical conferences per year. So she's able to stay at the cutting edge. She also co-hosts a radio program in the greater New York City area for the past 6 years called The Change.
Take
Take
charge of your health. The change. We can talk about that.
We will be talking about change. And she's also certified in nutrition from the Institute of Holistic Nutrition here in Toronto. And you can reach Carol via her Facebook page, Wellness with Carol or Wellness Carol. So welcome back again.
Thank you so much. I so appreciate this opportunity to talk with you again, Alex. It's great fun.
It's fun for both of us, but I hope that it's going to be a lot of information and education to women that, just to continue with our past conversation about women's hormones. How do you know? You're a woman. You may or may not have certain symptoms. How do you know whether or not bioidentical hormones or hormone therapy? How do you know that you require this?
Or that it would be helpful for what you're experiencing if that's a real problem.
Mm-hmm.
So I'll stick to the midlife and on area. And I really appreciate the work of Dr. Jerry Lynn Pryor at the University of British Columbia. And she's teased this out. Contrary to what everybody has been told to think, in the perimenopausal years, you actually stop ovulating quite often. So that wonderful surge of progesterone that occurs from mid-cycle, when the egg is released, to the end of the cycle, the big, huge surge of progesterone starts to be missing. You do have progesterone in the front part of your cycle that's often ignored by doctors. I just like to mention that the follicular level of progesterone is coming from your adrenal glands and not for the ovaries, but it's there, and it's there in abundant quantities. What Jerry Lynn Pryor found in her studies was that coupled with losing the luteal phase progesterone, we have the highest levels of estrogen in our entire lifespan in the perimenopausal years. So that huge discrepancy between estrogen, the stimulant hormone, and progesterone, the one that moderates estrogen, is at its hugest. And here is when women, surprisingly, start having symptoms. They're going along merrily enjoying their midlife years, and they're relatively young, and suddenly they start having troubles with sleep. They start feeling more anxious. They might have headaches. They might have water retention they never had before. They notice they haven't changed anything about what they're eating, and suddenly they're putting on weight, and nothing helps it. They'll try to starve themselves when they notice it happening because their clothes are getting tight, and you can't fix it. That woman is ready to start thinking about helping herself with hormones. And that's where progesterone is the first hormone that starts to decline, would be oh so helpful. So we call this huge discrepancy between progesterone and estrogen. When estrogen is high, relative to progesterone, which is low relative to the estrogen. We're calling it estrogen dominance. Now, this can be happening in your own body just as part of this aging cycle when you're stopping to ovulate, but it can be made even worse by estrogen-like compounds in the environment. It can be made worse by our microbiome, the wonderful 90% of us in our gut. The microbiome gets disordered, and you actually recycle the estrogen you've made, and it builds up. So you have an abnormal buildup of estrogen that you never encountered before.
Does estrogen make you gain weight?
It certainly can. Estrogen is the hormone that promotes storage of fat. It instigates turning those carbohydrates into fat, body fat, more readily. It also has a depressant effect on the thyroid gland. The thyroid gland makes mostly T4, a pre-thyroid hormone, which has to convert to T3 to be active. And when estrogen is relatively high, that metabolic step to make the active thyroid is slowed down. So you actually could check this. You could actually check that you start having lower body temperatures if you wanted to check that. But you'll notice that you seem fatiguey, you don't have the energy, you're not ready to zip out of bed in the morning. And some people are able to overcome some of the results of this low thyroid by slow, sustained exercise. And some people cope that way, actually. They'll be the ones who only feel good if they get to the gym and they'll do the bicycle, they do swimming. That slow, sustained exercise brings up your metabolic rate, substituting for what you're losing with the thyroid.
So are we talking about HRT or are we talking about bioidentical? What's the difference?
Okay, HRT, in general, hormone replacement therapy, hormone restorative therapy, however you're saying it. But my contention is, for the first time in human history, we can do this. We have available to us substances, compounds, which are made in the exact same chemical composition as our own hormones. So when I say to use progesterone to relieve some of the symptoms I just talked about, I'm talking about the exact molecule that our body makes. This makes it very testable. You can test pre and post. Now, the pharmaceutical industry has done us a huge disservice because they like to make little adjustments on that molecule, add a group here, add a group there, and it's not quite the same composition, but it is competing for those receptor sites in your body. It's close enough, but not quite. And there are dozens of fake progesterone substances out there. And then the pharmaceutical industry has done a great job of educating practitioners and encouraging them to use these substitute progesterones, saying, oh, it's absorbed orally better, it's lasts in the body longer, it's just as good, we can do it cheaper, any number of reasons. But I always wonder if doctors paid no attention to their organic chemistry and physiology and biochemistry, because if they were, they would see that it isn't quite right. And when it isn't quite right, your body responds in different ways, has different responses, has trouble getting rid of it. For instance, when the drug company says, oh, it'll persist longer, we think, oh, well, we don't have to take it so often. It's a good thing. No, it's a bad thing. Your body needs to excrete and get rid of these chemicals. I would say they're really chemicals. They're foreign chemicals to your body, and not really hormones, as they're saying, at all. They're a substitute. So you can be very careful and use just those hormones that your body makes.
So I'm glad we have a very good distinction between synthetic versus natural or bioidentical hormones. So anyone who's watching this should understand that when we're talking about hormone replacement therapy, we're talking about bioidentical hormone replacement therapy, which is safer, and more natural to your own hormones that you're producing. Let's talk about estrogen dominance, because I see it with a lot of women that I see, and I look at their thermography results, and I suspect that a woman, let's say in her 50s or 60s, and her breast may look like she is in her 20s and 30s, that her estrogen levels are probably elevated, that leads to vasodilation, in other words, dilation of her blood vessels in her breast. And that makes me suspicious about estrogen dominance. What can you say about this?
Well, you're probably just observing. The estrogen's a great hormone for your breasts. It's responsible for the development in your breasts in the first place. When you start having cycles in your younger years, it's the estrogen that's giving you the rounded hips, the waist, and the roundness of your breast. So there is some water retention, there's fat accumulation there. And actually, if you were to look at an older woman with shrunken, desiccated breasts, that would be a huge sign of too little estrogen, right? Because all that body composition is gone. But you make a good point. You can tell a lot about a person just by looking at them, yeah, about what's going on with their hormones. We talked about testing briefly. Yes, you can test, but how you present yourself clinically is also hugely important. For example, just the face, when you start getting into your 40s and estrogen, progesterone, some testosterone are declining, that's when you're starting to see the lines in your face. You cannot use the proteins that your body's taking in as well, because you don't have the hormone signalers to be helping your face. The estrogen not only helps your face be a little plumper and radiant, but it also helps elastin and collagen in your face. And so does progesterone and the muscles in your face. Testosterone is a great hormone for structure. It gives you your muscles and bones, and all proteins are under testosterone direction. So if you're starting to have a saggy face, that's an indicator that there's not enough testosterone going on.
Yeah, I
know.
So let's talk about menopausal or even postmenopausal women, because I get a lot of stories where they talk to their physicians, and their physicians will say, well, you're postmenopause, all your hormones will naturally drop, and there is nothing that you need to do about that. And I find that, especially in menopausal or postmenopausal age, many women will suffer not just with low estrogen, but generally progesterone level kind of drops to almost nothing. And even though their estrogen levels may still be low or lower, they're still in that estrogen dominant state.
That's absolutely correct. As closer you get to menopause and the complete stopping of all ovulation, estrogen is gradually going down, but it can still be dominant over its progesterone, which has been going down even sooner. So you can have some of these same things. A hallmark symptom of low progesterone relative to estrogen is mood, any kind of anxiety. And depression, if there's depression going on along with that, estrogen needs to be addressed. So how many women in that perimenopausal, menopausal age do you see being offered not hormones, which could get to the root of the problem and safe and relatively easy to use if you don't have some kind of an impediment to learning about it, but so much safer to use than antidepressant drugs, anti-anxiety drugs, sleep drugs. If women are starting to lose sleep, everything starts going downhill, and just adding progesterone will restore that sleep, which helps you recover a lot of ground.
So where do women go to get tested, for instance?
Okay, that's a great question. There's a number of ways that hormones are tested. And when we started, I've been doing this over 25 years. And when we started, women could go in and complain to their physician, and their physician wouldn't do something as simple as taking a blood level, which they could do easily and follow it. But they weren't taught that. And one of the reasons they weren't taught that is because they were also taught to use a drug like Premarin, which has about 50 estrogens and impossible to measure the consequences with a lab test. So why teach physicians to do that if when you tell them to use this sort of therapy, there's no good measure to compare to the measurement in the first place? Your measurement before and after taking Premarin for estradiol is not going to go up. It'll go up for estrone maybe, but doctors don't usually measure that. And then they're never going to measure the some 50 metabolites of Premarin. So you really don't have a good idea of that whole load on your body. As we're starting to use bioidentical hormones, now it makes sense. You can go in, have a blood test, and you can start using some hormones. And when you use the hormones, if you pay attention to when you took your last dose, and then when you draw blood for your sample, you're going to be on a curve, like, it's going to go up in your bloodstream and down. And so you'll be testing somewhere along that curve. What it's really telling you is not if you've taken enough or not too much. It's telling you that you absorbed it. It goes up into the bloodstream. As it goes down, it's going out of the body, one thing, and the other part of it's going to the tissues, exactly what you want. So serum actually is the most time-honored testing for hormones. However, there's some negatives to it. It's just a point in time. Mm-hmm. And particularly the earlier you are, perimenopause, a hallmark of perimenopause, for instance, is your estrogen swinging all over the place. So that one point in time might not have the significance in your perimenopausal years as your postmenopausal years. So then we had the development of saliva testing. And numerous labs offer this in the US. I'm not sure if there's a Canadian lab that offers it. So you just simply spit in a tube and send it off to the lab, and they're going to measure your hormones. Some advantages of this: it's non-invasive. You can get a lot of hormones tested at the same time. However, when we're talking about hormones and as we're aging, the amounts are tinier and tinier. One of the drawbacks of saliva testing is that they're at the very edge of accuracy for the test because there's so little there. So it's easy to have a significant lab error, and it could make you change your mind about what you feel. I think the saliva tests were a boon because patients started getting more access to testing. Some labs offered that you could get the testing done on your own order. So now the patient had a tool and could go to their doctor and say, look at this, I've been complaining and complaining and complaining. These are symptoms of low hormones, and I've done this test, and here you are. Sort of force the practitioners into a corner saying, okay, okay, now they're stuck. They have to learn something, or maybe they're going to lose their patient if they don't want to work along with the patient, which, in my opinion, any practitioner has to make that their priority. They're not in charge. They need to be a partner in healthcare with whoever's going to them. Negatives with the saliva testing are, again, just one point in time. And there's a few other negatives, but one of the main things that I'm going to bring up that really applies to all lab testing, and we can talk about urine too if you'd like, but blood, urine, and saliva, they're measuring the hormones in a certain body fluid. However, we know very well estrogens concentrate in the breasts, they concentrate in the uterus, in ovaries. So your muscle might not have as much as your breast does, or your skin might not have as much as your uterus does. And I just read a very interesting study, the disease endometriosis, where you get the lining from the uterus growing somewhere inside your belly, causing all sorts of pain. We know it's a very estrogen activated disease because more estrogen makes the pain worse. However, what they had looked at was measuring the blood estradiol levels in someone with endometriosis and somebody without. They had the same levels. There was no way to indicate that this person was having trouble with the endometriosis. However, when they checked the tissue in someone actually having surgery for endometriosis and then analyzed that tissue for estradiol, it was loaded, as you might suspect. So all of these testing can't really tell you the whole story. Testing is a nice tool, but you've really got to take it in connection with what is going on in that body. And then urine is a gold standard, actually. Urine is one of the best. You collect urine for 24 hours and measure about 40 hormones. And I like this concept because no hormone acts by itself. It's reliant on all the interactions with the other hormones. I really like because it introduced the idea of how important adrenal hormones are. When you stop ovulating and the ovaries are shutting down, a postmenopausal woman is very dependent on her adrenal glands. I would even call it adrenopause. The adrenals aren't working so well when there's symptoms at the menopause years. It's a adrenal dysfunction on top of a ovarian shutdown and slowdown.
Yeah, I understand that urine tests for hormones are becoming more and more popular because basically we're looking at the way a person metabolizes their hormones, what basically spills out. It's almost like reverse engineering to see how they function on a hormonal level, because again, blood is only in time. Saliva, you can also do several tests over a period of a month, but again, it's just in that particular time. But it doesn't tell you how you really metabolize. And I'm glad that you brought the example with endometriosis, because I know that also breast is a very hormonal tissue, and your blood results and other results may be perfect, and
Uh-huh.
your breast metabolizes, especially estrogens, on its own. So you may have an estrogen dominant breast with so-called normal or within normal blood test for estrogen. Very important information for people to keep in mind. Let me ask you about, where do women get, not just tested, where do women get help with who should be prescribing bioidentical hormones? Where do they go?
Okay. Well, in a lot of people's mind, you would think an endocrinologist would be the go-to person. And I beg to differ in actual practice. Endocrinologists seem to think that their domain is treating diabetes and maybe thyroid, and not that very well either. And if you go to most endocrinologists, they are going to be out of their comfort zone. They really don't understand it. And they'll say, go to your gynecologist. Well, the gynecologist is sort of interested and maybe a good resource in that collaborative thing, particularly when you're still cycling. But they lose interest pretty much in a older postmenopausal woman. Go to an internist. Your internist should be more like a general medicine or a family medicine. Well, they're interested in your blood pressure, cholesterol, diabetes, those sort of thing. And they are not trained to recognize that many of the chronic diseases that they're trying to medicate really have an underpinning of declining hormones. That if you go down to the basics and start addressing what are obvious hormone deficits and putting that back in, it will be amazing how many things just drop away and do not need your attention anymore. So that's an exciting place where we are now. For the first time in history, too, we have medical specialties in anti-aging medicine,
right,
or successful aging. And this is a good source. So if doctors have been trained through those sort of organizations, they know that good hormone levels are a pillar of successful aging. We have a group of doctors that are also getting certified in functional medicine.
I was just going to bring this up.
Yeah.
But functional medicine docs.
Yes. But, the colleges don't teach functional medicine. When you go to medical school, that's not a practice specialty. We have a long way to go with that. So physicians do go to courses and study pretty hard to get certified in functional medicine, which includes hormones, of course, but it will also include nutritional biochemistry, because we've lost our way, I believe, even though I'm a pharmacist and studied drugs. I know for sure drugs are not the answer. Drugs are designed to block your biochemistry. They're not designed to make it proceed in the way it's supposed to. And a lot of things that go wrong is there's some sort of blockage in biochemical pathways. So hormones are involved, vitamins are involved, minerals are involved, other substances that your body makes can be involved and helped. So this too, it's exciting times. You can work with people and help correct those problems, metabolic problems, in the realm of functional medicine. Now, to find one of these people is is not so easy. So the IFM, Institute of Functional Medicine, I think keeps a roster of their members. You could check there. But unfortunately, I have to say, their members aren't numerous enough to cover the needs of a very large population of people who could be helped.
Right. And never mind women. We can talk about andropause just like menopause.
Yes.
There's lots of men, and they also suffer from estrogen dominance because of, we really, with the environment, it's probably a huge environmental kind of impact on men and even animals in terms of estrogen dominance and also low testosterone.
It's interesting. We're talking about laboratory tests, and we're talking about how to measure, and then you compare your results against a range. And ranges for normals, for hormones, and a lot of things are on the decline because they're creating their normal ranges from the people they're testing, and we're declining. So the normal range for testosterone in men is a fraction of it was 50 years ago. And so when you go to the doctor and you're even at the low of the contrived new range, and they'll say you're fine.
Yeah, you're normal. Okay, thank you. I didn't think I was abnormal.
No, you're average or something. You're not normal. They use normal. They use normal, and where normal is not correct. Well, right. Let's just say the range, I don't know the nanomoles one, but say in the nanograms per deciliter, men should be, now maybe the range would go 300 to 900. And 50 years ago, it might have been 600 to 1500. So what's happened to us? It's really, really frightening. And men's sperm count is going down. Yeah. So we have new normals for that to make you fine, even though you're certainly less than optimal. And testosterone is such a huge thing. Easy to tell a testosterone deficient man. They're starting to grow breasts. They're getting
gynecomastia.
Fat in their tummies, and
I think
And
it resembles kind of what the fashion industry did to dress sizes, because
yeah, exactly.
the dress sizes it becomes smaller and smaller, so you still fit into dress size 6 or 8, but
Right.
it's all relative now.
It is. That's a very good metaphor for that. So we've adjusted our dress sizes. That's certainly true. The urine test. I just wanted to add one more thing. There's a lab offering spot urine test that you just use a piece of paper and you urinate on it. I believe it's 5 times through 24 hours. And I'm on the fence with this. I truly am on the fence. There's nothing in the literature to verify that this actually is a good estimate of what you could have had at 24 hours. There's a lot of averaging to get the numbers that they're coming up with. Like the 24-hour urine, it's good. It measures lots of hormones.
Right.
But I'm very suspicious about the results. But in general, I think you should be suspicious about the results anyway, because it should not supersede what you yourself are presenting as a person. And if the test says you have high estrogen, you have dry vaginal tissue, you're not high in estrogen. You don't have enough to keep that tissue healthy. So therefore, you can't be. And so the patient needs to be identified as the absolute end all. It's a big problem with thyroid. We've been measuring TSH for thyroid for many years. And people can walk in with pale skin, thin hair, overweight, depressed, and the TSH is normal. And the doctor forgets everything.
It's within the normal range, which also shifts, right?
Right.
In Canada, it's the range is from 0.35 to 5. In the United States, it's from 0.35 to 3. So
right, that's a recent change.
I think it changed about 10 years ago. It's not that.
Yeah, and
so
and not all labs in the U.S. have made that change either. So
fascinating, right? So if you're 3.1 in Canada, you're still normal. If you live south of the border in the United States, you will be actively treated for hypothyroidism, right? So all these changes, where do they come from? They took a healthy 18-year-old in 1917 and said she's normal, and now everyone has to fit into that box.
Yeah, I don't know. If you were to pay any attention to TSH, the optimum TSH in my mind hovers around 1. Right. And if you're not there, I already get nervous. And I would encourage people to demand. You are the customer, by the way. And you want to buy it. You want to buy a complete thyroid panel. You want to. TSH is a pituitary hormone. So you're just measuring whether the pituitary is able to address a call from the thyroid for more stimulation. Now, sometimes the problem actually is the pituitary, and doctors are forgetting to think about that too. The pituitary isn't working. It's secondary hypothyroidism. Right. It's amazing to me how many doctors never give that a thought. And then we have issue with a form of autoimmunity, Hashimoto's, where you actually have thyroid antibodies attacking your thyroid, but that's not the only part of your body it attacks. So we have a global autoimmune issue being ignored because somebody has a TSH that's normal.
And just so that everyone understands, TSH stands for thyroid stimulating hormone.
Mm-hmm.
Right. So, yeah, and listen, I think testing is a whole subject in itself for hours and hours, whether it comes to hormone testing, whether it comes to thyroid testing, and never mind adrenal testing, which is also very, very limited. We're just checking for DHEA and cortisol. I mean, there are some other things that could be not functioning properly. And as you mentioned before, unless your adrenal, you're kind of in an adrenal normal or healthy range, hardly anything is going to work postmenopausally, because
Mm-hmm.
it's the adrenals that take over your sex hormone production.
That's actually 100% right. And case in point, when a woman has an oophorectomy, the ovaries are removed. Why aren't you dead? Well, you're not dead because the adrenals are able to make up for it, or you would be dead.
No, it's very important, and I don't think that, especially because the adrenals, and not just the adrenals, of course, we're all susceptible to stress, and stress, literally has an effect on our hormonal level. So people under the prolonged stress, as many people today are dealing with elderly parents or divorce, or the political things that affects them, whatever it is that stresses you out, and unless you know how to deal and process that stress or that information in a healthy way, your adrenals are constantly under attack. The adrenals really don't realize whether you are stressing yourself with your own thoughts, or somebody
Mm-hmm.
stressing you out, or you're physically attacked in the jungle. They are still pumping out that adrenaline. And after a while, the adrenal system, or the adrenal glands, are basically get pooped out, and they can't put out the same kind of hormones as you were getting when you were in your 20s and 30s. And that creates a whole hormonal cascade, because everything is affected. We're talking about the endocrine system. We're not just talking about the breast or the thyroid or the ovaries. They're not. We have a tendency in Western medicine to to put things and to kind of put them into boxes, but really they're not in boxes. It's a whole very, very integrated soup. It's not just one or two ingredients.
Yes, physicians are taught in medical school, and maybe other practices too, to think in a very linear flowchart fashion. If this yes, go down here, yes, no, yes, no, yes, no. But it really is multiple global thing. And that's been one of the troubles with physicians getting involved in offering hormones to their patients, because they have to shift away from the way they were taught, that very linear kind of thinking. I'd like to just mention one test that I have been recommending to people, and you can really have this done anywhere, but if you go to Life Extension, lef.org, in the US, they offer testing that patients can order themselves, but I like the male elite panel and the female elite panel, which is all done on the same vial of blood, or vials. It takes about 12. But what I would like to say is that test measures pituitary hormones, sex hormones, thyroid hormones, adrenal hormones, inflammatory markers, blood chemistry. And if you go there and download what's in that test, you can actually go into your doctor and request those tests. They're pretty normal lab tests that could be done by any major lab, so there's no big impediment to doing it. So it can either, if you're in the US, you can actually order that through Life Extension for yourself. If you're in Canada, for instance, just download what the tests are and ask your doctor to please order them for you. And I really like that, because, for example, they'll be testing homocysteine, and homocysteine in the blood is a cardiac marker, because it irritates. It's an irritating molecule, irritates the endothelial lining of the blood vessels. It's the start of calcification in your blood vessels, which are simply a Band-Aid for that irritation. So homocysteine is a cardiac marker, but it's also a marker for not being metabolized to the next thing, which requires B vitamins primarily. And when your body's not metabolizing homocysteine very well, you already know that you're not going to be metabolizing your hormones in, as well as you could be. So you can look at different parameters that pertain to hormones, but are not actually the hormone itself, and get a lot of information in the same test. And I love that. I love the collaboration of different markers and coordinating that with what you find on the test. So for both of those panels, they leave out the thyroid antibodies, but they could be added, and should be. 60% of people really are low thyroid because of antibodies. So it's a big problem and very often ignored.
And I'm glad you brought this up, because next time maybe we can talk about generally inflammation.
Oh,
That's another subject for hours and hours and hours. And I thank you so much. It never ends. The more questions I ask, the more answers I get, the more questions I ask, and we can go about talking about this and many other subjects for days on end.
I know.
What we do when we meet in person at different conferences. So I thank you once more, and we'll have to do this again,
Yeah.
and again and again.
Yeah, no, I'd be delighted, Alex.
That's great. Thank you so much.
Okay, thank you.